such a good microsurgery to my surgery is a big jump. Anyway, I want to share with you my effort to try and preserve the visual acuity, the ocular surface of a patient with conjunctival melanoma. Conjunctival melanoma accounts for 2% of malignant tumors and no gender difference. Caucasians, people in the 40s are the typical patients. Location may vary. Limbus, but also the caruncle with the worst prognosis. Beware of PAMs because they can lead to melanoma. This is my clinical case. It started in 2013, a 47-year-old woman with discomfort in her left eye, ptosis, with amblyopia in the right eye, the good eye in brackets, 10 on 10 in the left eye, and you see there is a mass, a pigmented mass in the fornix, and we can see it very well on the slit lamp, a pigmented mass, and you see seeding in the plica semilunaris, and the PAM extended to 4 quadrants and to tersal conjunctiva of the upper eyelid. And so we refer the patient to the oncologist. This is the work up, everything negative. So we move to surgery. We follow the guidelines of the shields with the so-called no-touch technique surgery, the highest excision biopsy possible, reconstruction with amniotic membrane, and as you know, all the rest. And this is the histological examination. It is a conjunctival melanoma, epithelioid cells on primary acquired melanosis, infiltration 1.2 millimeters, number of mitosis 2, and also in plica semilunaris there was an infiltrating carcinoma. The rest is a PAM. According to the AJCC staging, this is a PT2B NOMO melanoma. And 5 days post-op, this is the lady. You see the membrane tends to reduce with no sign of discomfort, and the sentinel node is negative. This is January 2014, and March 2014 we do a cycle of mitomycin C. Professor Balestrazzi was commenting on mitomycin C. We do 0.04 concentration, 1 drop 4 times a day. And we send then our patient to follow up. This is March 2015, a very good ocular surface, no type of recurrence. And then September 2015, no signs of local relapse. April 2016, unfortunately, things change. We see an increase in pigment in the conjunctiva in the upper eyelid. Oncological examination, in this case, zero tolerance for pigment is necessary, might be a relapse. In May 2016, 1 month later, pigment extends, and this is the problem. Under the upper eyelid, there are numerous pigmented nodules covering the whole upper eyelid from one end to the other. So we are in front of conjunctival melanoma relapse. So all the exams are negative, so we opt for surgery. This is a 2-steps surgery. Removal of conjunctival bulbar lesions, brachytherapy is done with ruthenium 106 after 1 month, and then full thickness excision. So the excisional biopsy of conjunctival lesion is fine, complete removal of the lesion. that was again positive for melanoma, brachytherapy with ruthenium 90 grays, and in September 2016, as the eyelid, ptosis increases, and you see there is also seeding in the lower eyelid, and you see this is completely visible. So we have to remove all the eyelid, and this is the excision, and this is intra-op biopsy, and this is the upper eyelid, and we can decide the type of reconstruction to be done. Everything is negative, and when we are in such a situation, the main goal is the protection of the eye. We have to continue, we have to respect facial asymmetry, occlusion. So we have to try and obtain more and more. And thanks to the interaction we have with our multidisciplinary team, we opted for using this flap, temporalis fascia flap. This is the dissection, the opening, detachment, the gallia is opened, the temporalis muscle is visualized, and then the fascia is dissected and then rotated inside the hole, the defect, and I have sutured the fascia at the level of the stump of the levator palpebralis, and I keep my fingers crossed for motility. This is the fascia, this is the muscle, and this is the end of surgery, and the skin flap, and this is 2 days after surgery, and this is the best thing. You see, it's not beautiful to see. I mean, this is scary, but there was motility. It could move. So we believe it, and then we get the result, the final result, and we know that we've made it, and then it starts pigmenting, and slowly but surely, up to 40 days, things start to change. Also at the cosmetic level, we opt for mitomycin C eye drops 0.04%, and this is 5 months after surgery, and this is 10 months after surgery. This is beautiful. The eye surface is the ocular surface is perfect, and she has improved the visual acuity. In 2 years, we have 8 on 10 in the left eye, with good motility, a good cosmetic and functional result. Almost 20% of patients with conjunctival melanoma die for metastasis. It is a rare but fatal carcinoma. Local relapses account for 56 to 65%. When there is a relapse, you have to be very aggressive. Thanks to the no-touch technique, maybe there is a lower risk of local relapse and lymphatic metastasis. Surgery is not enough. Something more is needed, such as the brachytherapy I've shown. Management is complex. You have to rely on a multidisciplinary team. The ophthalmologist cannot make it on his or her own. Thank you.